Good morning, everyone. Welcome to the Last Visit First podcast. It's the number one podcast in the post-acute care industry. Today, my guest is Dr. Chet Robson, a physician executive, healthcare strategist, and advisor with deep experience spanning clinical care, population health, value-based care, digital health, and healthcare innovation. He's a board-certified family physician. Dr. Robson has served as leadership roles, including Chief Medical Officer at Adventist Health Partners, Chief Clinical Officer for Walgreens Office of Clinical Integrity, which we'll get into that, and Chief Medical Officer at Your BioHealth. Throughout his career, he's helped health systems, providers, payers, pharmacies, and healthcare technology companies navigate clinical transformation, healthcare technology adoption, and new models of care delivery. Today, he advises healthcare organizations on emerging health tech companies focused on improving patient outcomes through technology, data, diagnostics, and innovation care models. Dr. Robinson holds a Doctor of Osteopathic Medicine degree from Midwestern University and a Master's in Healthcare Delivery Science from Dartmouth College's Tuck School of Business. Dr. Robson, welcome to the show.
Great. Thanks, Tom. It's great to be here. I'm looking forward to some interesting dialogue.
Yeah, it's true. Let's get started. Tell us about your journey. So walk us through your journey as becoming a physician and then kind of all these great roles you've had over the years.
Sure. Well, I actually came into medicine a little later in my life. Went to medical school, and then I'm based here in Chicago. Did my training here in Chicago and my residency. Went into family medicine. I really enjoyed the broad aspect of working with people across the age spectrum and across the illness and health spectrum. Pretty quickly, though, when I first started, we were still in the paper chart area, and we were just moving towards electronic medical records. And at first, I hated them just as much or more than anyone. But I also realized that it was the way that we were going to practice medicine from there on out. So after, kind of wrestling with myself, I decided, you know what, if I really want to provide good quality care, I need to become an expert at using this tool and figure out how does this work and how do you make this benefit patient care. So I started going back to the company, our EMR company, and taking courses and classes and working with the tech developers and so forth. So I learned some of the technical side, but also from other clinicians using it, of how they were using it, and quickly, it began to be a tool rather than a barrier. So with my health system, of course, then I took it back and became the go-to person within the health system of, how do you use this and help them to implement it for other physicians and nurses and clinics. And I worked almost primarily on the outpatient ambulatory side. So I became the chief medical information officer then for our health system, across that span. What that does, though, is it begins to take you out of clinical medicine and more into the administrative side of things. After doing that for about 7 years, I transitioned out of patient care and more into the administrative side. That's when I did my master's at Dartmouth in healthcare delivery science, and looking at all the different ways that healthcare is delivered, partly through health systems, partly through consumer health, partly through a number of other venues. Digital health was just beginning to be on the front, telemedicine at the forefront. And then that's what took me to Walgreens, because at that time, Walgreens had just acquired Boots Alliance. So at that time had just become the largest pharmacy company in the world in 25 countries. So the opportunity of looking at how healthcare is delivered, not only in the United States, but across, that broad spectrum and in many different ways. At that time, there were, Walgreens was involved in lots of clinics, specialty pharmacy, retail pharmacy, digital health, a number of healthcare delivery mechanisms that I found extremely, extremely interesting and some great opportunity there. I worked with Walgreens then through the end of COVID. By that point, I was fairly well burnt out from having dealt with COVID in 25 countries, and transitioned kind of semi-retirement, I thought, and then really just helping to provide some of that experience to a number of startup companies in a whole number of sectors. And that's what I'm still doing, is working, consulting and advising in fractional chief medical officer work for some various startup and mid-sized companies.
That's cool. What EMR were you on back in the day? Was it Epic back then, or was it Cerner?
So I worked with a number of different ones. Our hospitals were using Cerner. on the ambulatory platform, we were using NextGen, which was a really interesting platform because it was built as a kind of a custom, where you could customize it a lot, when you have just a single practice is really good. When you have to start doing that across multiple practices, it becomes a bit more challenging. So it was a great way to learn both your kind of customizable EMRs as well as like the Cerner platform, which was a large, single function, system. From that, then we went on to other Athena and Epic and a number of others. From there, at Walgreens, we were on Epic. So I've worked with, I think over 50 different EMRs over the course of my career.
Yeah, I cut my teeth. We had a product called Millbrook Practice Manager and then Millbrook Paradigm. And we sold that to GE and became Centricity Physician Office. And that's where I started my career after I got out of the military. So I'm real familiar with that one. Yep. Yeah, it's still around. That product's still around. I don't know if they've changed it or not, but it's still around. What lessons from practicing medicine still influence your leadership decisions today? I mean, you took care of a lot of patients, and now you're dealing with technology. So, what things changed you, or what made you think different about EMRs?
Well, like I said, part of it was realizing that EMRs are simply the way that healthcare is going to be practiced from here on out. But what it did is it began to open me up to some of the data collection and then the quality management that can come out of that. Because I can remember so much in my clinic, we wanted to do a little quality project. So we thought, well, especially in primary care, we should just take a look at how many of our patients that are being managed for hypertension also still smoke, because, we don't want them to be smoking, right? And I was in a practice of about 5 physicians. So of course, there's also a little bit of competition so I was sure that my patients, I would have the fewest numbers of smokers. But when we pulled all the data, we began to realize a couple of things. One is that how the data is input affects very much what comes out. So you need to make sure that the input is very accurate. But second of all, that in fact, when you begin to look at the actual outcomes, that it varied from what we kind of thought. The thing that was cool about it that really got me going was that within just a month or so, every single physician in the office, their number of people smoking decreased significantly. So be able to see that positive impact on patient outcomes by allowing physicians in the office to see the actual data of what was actually there, really that began to really excite me to say, EMRs and technology have an ability to uncover things that we would have never been able to do, in paper charts. And then from there, some of the other technologies of digital health, what happens when you begin to put some of that information to the patient and the consumer so they can see their own information? What happens when you have telemedicine, where now you can have a platform for the clinician to be able to interact with the patient at home? So all of these technologies, they're always challenging in the beginning because we're just learning the technology. But as you begin to utilize them in a way that makes sense for both the clinician and the patient, it unlocks a whole ability to be able to provide care that we previously were. Now, of course, we're entering the age of AI, and of course, there's lots of concern about how it works and so forth. And again, it's a little bit of the unknown. But as we begin to realize that providing some AI information both to the patient and to the clinician, and provide ways for that information then to accelerate that relationship, I'm just excited about what technology can do for healthcare as I was back when I first started with EMRs.
Yeah, I'm with you there for sure. I was just thinking about, and having a conversation yesterday about, all the patients that come into the hospital, the ER or the clinics that need a translator, right? So you have to have a translator come with you. I mean, now translating whatever language you have, we can translate it with AI in 2 seconds. And it's unbelievable how good it is. And as long as they can read, if they can't read, then we can translate it with, I got these Meta glasses over here that I bought. We took them to Italy, and you can translate that in multiple languages too. So you can sit there and give the patient the glasses, and you could talk to them, and they could hear it in their language. It's amazing.
That's so cool.
Yeah, the technology is coming, and it's coming faster and faster. All right, what separates a great physician leader from a clinical leader, from great clinicians? As you transition, that's an easy, interesting transition.
Yeah. That's a great question, and one that many physicians have to go through. And in fact, there's been a lot of studies, and there's been enough that are made transition. There's some kind of interesting things. The first is that when you're a clinician, generally you're the head of the team. You're the one making the decisions. You're the one who has people that report to you, right? And so sort of your word is the way it happens, right? When you transition into a leadership position, whether that's within a hospital organization or within a commercial organization, right? You become a part of a team, right? And often you're not even necessarily one of the lead people of the team, right? Generally, the financial people have a bigger lead in a lot of those organizations than the clinician does. So part of it is learning how to be a part of the team, but also to have confidence in your expertise and how that expertise intersects then with the bigger picture of what's being looked at. And that's definitely a skill set that you have to learn, because in medical school, we learn clinical skills. We don't necessarily learn business skills. We don't necessarily learn some of the, sophisticated financial management skills that these corporations, have to have. So being exposed and having at least an understanding of that becomes really important in that transition.
Yeah, for sure. And it's funny. I've worked with a lot of physicians in my career, and a lot of them don't know anything about business. They're really good clinicians. They're great clinicians, but they don't know how to run a business. And they're like, "What do you mean we don't have any money?" Well, doc, we had to pay all these bills, and well, we're billing every day. And I'm like, "Yeah, but you got to manage all these people, and you got 3 nurses and all that."
Yeah. I think quite often too, physicians, I see this especially in health systems. As a clinicians, your primary goal is the health and welfare of your patient population. You want to see them get better, or to see them, have good health outcomes. And you're very focused on all of those clinical dimensions, right? And sometimes it gets frustrating because you're going to the CEO of the hospital, or, the CEO of the company, and you just want things to be focused for that outcome. And you don't realize that the CEO of the hospital, what they're measured on is on the financial outcomes of that institution. There's a whole number of factors that they have to be looking at, right? And so it's hard sometimes for clinicians to understand that there are other objectives in the whole healthcare business. And all of them have to be in place. The old phrase of no margin, no mission is very, very, very true. And of course, that's one of the exciting dynamics, is figuring out what that margin should be and where it should go. But there is more to the business of healthcare than just the mission.
Yeah, I always think about those scenarios, a little bit of a tangent here, but you go to the doctor, you give them all your information, spend an hour filling out their forms, their health questionnaire, you're answering, does your dad have this? Does your mom have that? And then you go to the next, physician specialty, whatever, and they give you the exact same form, and you're filling that out again. Then you go to lab and you're doing it again. Then you go to x-ray, you're doing it again. And there's people on the other side of that. So I, think about, okay, the patient's got to deal with this. They hate it. There's people on the other side of that are keying all this information into the same EMR, which it's already it. And like, why are we doing that? It's interoperability is a mess, and it's just frustrating.
Oh yeah, you hit on one of my raw nerves. In fact, one of the reasons that I kind of finally ended up sort of leaving the health system world and moved more to the commercial world, although it's definitely not perfect there either. But one of the challenges, in health systems is that over time they've had all these different systems, like we were talking about earlier, and those systems don't really talk with each other. And so you end up, and health systems are complex. You have all these different specialists, and you said all these different divisions, and unfortunately that information doesn't cross the way it should. And I think that's been one of the really big hurdles to value-based care, because it's impossible to try and assess total cost of care when you can't assemble all the total cost. So,
yeah, it's a definitely an area where we should be better. It's funny, when I was working with Canada years ago when I was at Millbrook and Centricity, and the Canadian immunization system was phenomenal. Like if you were a kid and you got your polio shot or measles or one of those, it went into a national record, and they could look you up anywhere you went. In the US, we can't do that. I got to go to the doctor, print my shot records, kick them to the school. Like, are you kidding me? Like, come on, guys. It's not that hard.
it's interesting. When I was at Walgreens, we set up a pharmacogenomics program, just phenomenal program. But the country that we ended up setting up, because we looked at, like I said, we were in 25 countries, so we looked at a number of different places. The places where we ended up setting it up, and it actually was very successful, was in the Netherlands for exactly that same reason, because they have a single EMR system for the entire country. So every provider, every health system, every pharmacy, anyone who provides care to a person in the Netherlands, including the government payer system, all uses a single EMR record. Well, that makes it so much easier because now you have one record to access however it is. So it definitely helps to solve many, many problems.
Yeah, it's a great, and I did some work in the Netherlands too. That's a good system. Norway's the same way.
Yeah.
They have a single EMR and a single payer. And
Yep.
I don't know that we want to get to that in the US, but why can't the EMRs talk to each other? Why can't Cerner talk to Epic and Epic talk to home care home base?
Yeah, and you don't even need to have a single payer. I mean, I think they had, multiple payers, right? But they had a single record that all the payers could look at. I mean, it just, to me, it makes much more sense to have, the one singular medical record that everyone can interact off of.
The U.S. banking systems figure this out. We exchange money pretty easily. And so why can't we figure it out in healthcare? And it's all money. I mean, I'll tell you what it is. It's all money. Epic doesn't want to talk to Cerner. Cerner doesn't want to talk to McKesson. McKesson doesn't want to talk to home care home base. And it's money. It's all about money.
Yeah.
All right. As the former CMO, what was the biggest mistakes organizations made implementing technology that you identified or saw?
So it's a great question. I think the primary thing is that they tend to think about the technology. They want to put in an EMR system, or they want to put in a system, for their financial management, all those kinds of things. But what they really need to be thinking about is what problem are they trying to solve and for what population, and then finding a tool that integrates with their entire system of care. Because what I saw happen too many times is there would be a new bright, shiny object come out, right? There's this new EMR, there's this new ambulatory EMR, there's this new radiology practices, there's all of these things that come out, and it's really cool, and what it can do is cool. And so we want to tend to be, state-of-the-art care. So there's a tendency to adapt the bright, shiny new objects without taking a bigger context of thinking, what problem are we trying to solve, and will this solve that problem within our current landscape? So that's the biggest thing. The second thing is that there was almost always way too little time spent training the people who are going to use this, how to use it correctly so they felt fluent and easy to use before it actually went live. I mean, I can remember sometimes there would be training for there would be 1 day of training to put in an entire new EMR system. It's like, it was not a great thing for anyone. And then the other thing, it kind of goes back to the first thing, is that there's a tendency, again, to be technology focused rather than patient focused, right? Is this really going to make the patient experience better, right? And it's difficult because, the technology is never going to solve all the problems, right? But the thing that, at least over the course of my career, that I found, is that when you have clinicians that are utilizing the technology well, then you start to have really great solutions. But when you start depending on too much of one or the other, that's where, things are going to break down.
Yeah, I'll give you a great example of that. So I have this concierge doctor that takes care of me and, does all the blood work and all that stuff for me. So she wanted to schedule this 3D scan of my heart, right? It's like one of these new things. And I'm like, okay, that's cool. There's a company in Scottsdale that does this. I had that test done a month and a half ago. And as soon as yesterday, they've been texting me to schedule my heart scan. And they text me and say, I've already done it. I've already read the results. I already know what it was. It was good. Like, what is wrong with your broken system? And they continue to text me and they call me and now I'm a patient that's frustrated. I'm like, what are you talking about? And I at least know a lot about healthcare systems. So I'm like, I already did that test. And then I respond to their text. I did that test. And they're like, you can't respond to the text. You got to call this number. I'll call the number and wait 20 minutes. I'm like, just keep texting me. Have fun with it. It's totally broken. So your point is right. If you don't have the right training, you don't have the right adoption, you don't have the right testing of your technology, all you're
Yeah.
gonna do is frustrate your patients.
Yeah,
And guess
yeah,
what?
yeah, yeah. Well, and I think that's the challenge for any larger organization. One of the things that's been, I think, really difficult for health systems is to change from being a hospital to being a system, right? And so they tend to still think of themselves as a hospital, right? And what goes on in the hospital, that's the health system. And they've, not many of them, some have, but not many have been able to make that leap to we're an entire system that has all these different levels of acuity and all these different types of providers and all these different patient engagements, and we need to be able to communicate across that, right? They still are extremely hospital centered. That happens on, I mean, with a large company, right? There's a tendency to think about what happens at the headquarter, right? What happens there instead of what happens at every single place that you're providing, services and all the different types of services. How does that all integrate into one single platform?
Hey, I have a question for you, a little bit off script, a little bit, but and I was thinking about this yesterday, and I was talking to Bud Lingham, who used to be the chief clinical officer at Habit. And one of the stats that we were talking about is 40% of the population gets discharged from the hospital with orders, or sorry, a larger percentage, but 40% of the population that gets discharged at the hospital with orders for home health never goes into home health. Why do you think that is?
Right. It's interesting because it's almost exactly the same statistic for pharmacy, right? About 40% or more of the patients who are prescribed a medication never pick it up. Right. So that disconnect between patients being given instructions for medications, for follow-up, for labs, right? There's a significant, not a little, a 30 to 50% population that never happens. I think it happens for obviously a number of reasons. One is because I think quite often the patient doesn't necessarily understand either exactly what they're supposed to do, in that they might think, I'm feeling better or I'm feeling this way, so I don't think I need to do that now, right? I think that's a big part of it. The second sometimes is that the patient doesn't necessarily understand they're supposed to go and do it, right? They think of this maybe more as a suggestion, if this doesn't happen, then maybe go do that. They don't necessarily see it as you need to go do that, right? I think the third thing is sometimes just the complexity of doing that. Quite often in those situations, you're talking about a person who has some degree of illness, some degree of inability to function the way they normally do. Well, if they're having to go someplace and do something when they already don't feel well, that's probably much less likely going to happen. And they might not have a care system that's able to get them to some of those places. So I think that all of those things factor into it. One of the other things that we used to deal with, just like you have no idea from a pharmacist standpoint, because what happens is you're on a formulary, right? You've worked with your doctor for 10 years. I've been on this medicine. You get admitted to the hospital and they change the medicines because they have a different formulary, right, than what your outpatient does, right? When you get discharged with a prescription for what the hospital has. The patient goes to the pharmacy and the pharmacist goes, well, all of these medicines are similar classes, but they're different medicines. So which of these do you need? The patient has no idea. They have no idea because just that communication between the hospital, right, and the outpatient never happens. I had one time a patient early in my career who he was kind of, I'll say, towards the last year of his life. He had COPD and a couple of other things. And he had children that lived in about 3 or 4 different places in our town, in our city, in Chicago. So quite what would happen is he would be at one of his children's house. He would have an episode. They would take him to the local hospital. He would get admitted. Then he would go into rehab there. He would get out, and then he would come see me. All new medicines, right? Then he would be in a different child's house. You can see how this works. Pretty soon, he had been to 4 or 5 different hospitals within the course of about 9 months. His daughter would bring in bags of medicine saying, what should he even take? Again, that lack of communication between things, right, means that patients get really confused, caregivers get really confused. Sometimes the course, the clinicians don't even know what's going on in some of those other places. So, again, that lack of communication really makes it difficult. And I think that's one of the big factors in that 30 to 50% lack of follow through for home health, for ambulatory follow up, for pharmacy, for labs, for radiology.
Yeah, that's amazing. And then you think about all the cost associated with that. Writing the prescriptions, filling the prescriptions. They have the same prescriptions. They're wasting these because they changed it to this one. And it's all, I think it's all based on the system that we're trying to hurry as fast as we can. We don't have enough doctors. We have too many patients coming in. They're rushing the process. They're not doing a good clean screening. And we're just wasting money. It's wasted taxpayer dollars. Everybody on this call, everybody that's listening to this, we're wasting your money.
Yep.
It's got to be fixed.
Yep.
Hi, I'm Jennifer Maxwell, CEO of Maxwell Tech. If you operate a hospice today, you know that the cost of bereavement just went up. As of July 12th, a first-class stamp increased to 82 cents. That means 1,000 bereavement letters now cost you $820 in postage alone. And that's before paper, printing, or staff time. Multiply that across every family you serve every single year, and the cost adds up quickly. But this isn't really about just saving money. It's about asking a bigger question. Is there a better way to stay connected with families after someone they love has passed away? We believe there is, and it's called NanaConnect Bereave. NanaConnect Bereave automates personalized text messages to families throughout the entire bereavement journey. You get to determine the messages and the timing. Support reaches families right on the phone that they use every single day and at the moments that matter the most. I want to be clear here. We are not automating compassion. We're automating the administrative work around compassion. Technology should never replace the phone call, the counselor, or the human connection that makes hospice care so very special. What it can do is make sure your team knows who exactly needs that connection so that you can spend less time on stamps and more time on your people. Because hospice doesn't end with the patient's last visit. If you'd like to see how NanaConnect Bereave can work for you and your hospice, contact us at sales@maxwelltech.com or visit us at www.maxwelltech.com.
Every year, millions of Americans are being discharged from the hospital and into a post-acute setting. And the process is broken. Telehealth has solved a number of problems, but we started with primarily providing insights and data to an industry in post-acute that had no insights or data to run their business. We wanted to change the industry, provide insights that really made a difference so that people could see the truth in what's happening and have real visibility and transparency in the market. No one had that type of data, and we were the first to be able to provide it. From that, we saw the next problem, which as you think about our personas that use our products, one of them was the sales department. They had no way to really manage the relationships with the physician, so they needed a CRM. AI is going to be embedded in every one of our products, and it's going to be the lead of everything that we do. I think what we're finding is we're in the most exciting time ever for healthcare and technology. I love the fact that we're every day getting closer to the patient to improve the patient outcome.
All right. Well, what technologies have delivered the greatest clinical impact that you've seen over the last decade?
Yeah. So, that's a really interesting question because, partly because it continues to evolve. And I'll kind of take like the biopharma and that part of it kind of out of the equation, kind of look at a few of the others. I think that definitely telemedicine has made a huge shift in how we interact, in how we connect. Right now we're beginning to see, in fact, in my estimation, a little bit unfortunately, right? There's this circumventing of traditional healthcare so that people can go directly just a single provider for a single medication for a single disease state. Okay? But telemedicine does allow, a direct person at home to communicate with some degree of clinician. And that's really changed the landscape a great deal. The second thing is all of the wearables, almost I saw, I think a statistic the other way, something like over 90 million people have wearables, and over 66 million of them actually use them on a day-to-day basis, right? So all of the, CGMs, the Oura Rings, the Whoops, all of the different devices that people look at, all of the different kinds of data, so that they begin to see some patterns. That has very, very much changed how people look at healthcare. And then, of course, electronic medical records, digital health, and now, of course, the one that's really beginning to impact, all of those areas is artificial intelligence. Artificial intelligence is beginning. You probably have more up-to-date information than I do, but the number of people now that go to AI with their medical, it used to be they'd go to Google. They don't go to Google anymore. They go to AI and they take information, they plug it in, and they let AI kind of be the doctor, the diagnostician for them. It's definitely changing it, So, I guess if I was to sum all of that up, I think the biggest shift we've seen is that consumers are doing more care at home and doing more research and doing more treatment, so the entire medical landscape has moved from you either have to go to a clinician or a hospital, or a clinic or a hospital, to many, 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 many things you can go at all levels of acuity, from, simple things, which we've always had, taking care of cough, a cold, of allergy, to, many, many, many of the chemotherapy medications that used to have to go in and do IV infusion, right? They're given it at home now, right? Which means the level of acuity of care, there's, home health, home, hospitalization, home care, all the way to the very advanced levels of care that happen at home, right? And that's a very big shift from where if you were sick, you had to go somewhere, to now you have to bring the care into the home.
Yeah, I think it's one patient desired, right? Patients want to be at home with their remote control, their dog, their cat, their families, and all that.
Yep.
But also, too, it's so expensive in the hospital. The hospitals are trying to get patients out of the hospital quicker so they can fill that bed with the next person, especially based on the DRG payment system, right? So you only get paid a certain amount of money. And so, you said it earlier, there's a financial driver, there's a clinical driver, and then it's also a patient desired driver, too. And we see that.
Yeah.
Our patients are getting sicker and sicker. They have more advanced, challenges. We're doing more kind of extensive services for our skills, if you want to call it that. It's interesting. But I love how you said that. It's really evolved, and you've seen it. I mean, you've seen like the first EMR from paper, and then you've seen it digital health, and you've seen this telemedicine thing. And thank goodness we had telemedicine during COVID, because nobody wanted to bring people into the hospital.
Yeah.
Thank goodness it was there. But and I think it's continuing to advance. It still blows my mind that in home health we can't do telemedicine. We can do telemedicine, but you can't get paid for it. It doesn't count as a visit. And really?
Well, which is funny, because home health is exactly the original home care delivery system. Before any of the other home care delivery systems, home health was the first one, right?
Right.
And you're exactly right that we don't do telemedicine in what was, now, admittedly, there's wound care and a number of, aspects where you got to have someone, touching base, but, a lot of that long-term care is monitoring as much as specific intervention. So.
Yeah, if Nana has a problem with one of her medications, she can get on the camera, show us her pill. We can say, hey, what's causing this? Side effects are normal. You are going to get dizzy. You do need to take care. There's always a need to be in the home, but could we do 10 visits in the home and 4 virtual visits versus 14 actual visits?
Right. Yeah.
All right, let's jump into population health and value-based care. So what did the industry get wrong about population health and value-based care? You've seen this thing change multiple times.
Yeah. Well, I think a couple of things. The biggest one I think we've kind of already talked about is just the interoperability. It's impossible to look at, an entire population where you can't even pull all the population's information together, right? So, and there's very, very few health systems that have been able to aggregate all of that information. The second thing is that, especially in the beginning, I think it's beginning to change some, but nobody was really trained to look at all of that data, to be able to pull all that data together and say, what does this mean? And what does this mean? And right? Because you can assemble data, but data doesn't provide insight. Data just provides information. You have to have ways to be able to put that together to say, so what does any of this mean? And then I think the third thing, which is a little bit more complex, but is that it's such a shift from providing funding to a single health system or hospital, right? To how do you attribute the population, right? Because people don't necessarily stay in one health system, right? They get their care at 5 or 6 different health systems, and they travel to Florida for the winter, and then they go to Europe for 2 weeks, and they're getting care, and then some of their care like that, they're going to the local clinic or the local, so they're not getting all of their health care in one attributed facility, right? But the payment systems were set up to pay a system for managing instead of paying, right, based on where the patient was getting care. And then again, encouraging the interoperability of those systems to say, let's work together to manage the patient. They said, no. Don't let the patient go anywhere except they have to stay in our health system. And you're seeing that, Medicare Advantage is, a number of the insurance companies, it's difficult because if the patient gets care out of network, oh my gosh, it completely changes. So I think that, there's to me, there's kind of 3 primary reasons, but they each are a major contributing factor.
Yeah, I mean, Nana's, got COPD. She's got ESRD or end-stage renal disease. She's getting dialysis at DaVita. She's getting her meds, some of her meds at Walgreens, some of her meds at CVS. Some of them are being filled by a local, compounding pharmacy.
Yep.
She's going to this doctor over here because she really likes him at the hospital, but then it goes to, the different system. And, we see that, right here in Minnesota where I'm sitting there's, Alina and Fairview and DaVita and all these different systems. And none of those guys are talking to each other. And so who gets paid for Nana if she's high risk in value-based care? It's pretty well. What are the biggest barriers to effectively managing those high risk populations? I mean, we identify someone that the high risk population, these are the people that are going in and out of the ER all the time, in and out of the hospital all the time, in and out of multiple hospitals and ERs. What do you think the biggest barriers are to managing them, other than interoperability?
Yeah, well, I think the first thing is because our healthcare is extremely fragmented and siloed. The first thing is being able to look and say, why is this patient high risk? And generally, they're not high risk because of one thing. They're generally high risk because of complex, multiple, morbidities. And so being able to look across that and say, what are all the factors that are making them high risk? That's one. I think one of the great successes the Mayo Clinic has done is that they have that broad-based approach, and some of the really large health systems do that. And I think that's much more effective for high risk to be able to look across multiple specialties simultaneously. The second thing, though, is that generally, people who are high risk, they also have really complex needs, right? So how do you provide like that? The medications, the lab testing, the radiology, the whatever care thing, all of those multiple complex things, you're getting beyond what a caregiver can do in the home, right? It has to be complex management that integrates between home and hospital, because the person quite often is going in and out of those things on a somewhat, regular basis. You have to be able to manage across those transitions of care, and in both of those settings with equal amounts of information and skill. And then of course the third aspect again goes back to money, is how do you think about paying? Because what's tending to happen is the radiologist gets paid and the nephrologist gets paid, and each of these, right, this hospital got paid and that imaging center got paid. And the toss from the insurance standpoint is, oh my gosh, we're paying out all of this money, and again, instead of having a coordinated payment system that focuses on the patient, right, it's still focusing on all the silos.
Yeah, it's pretty amazing when you, if you ever go to the ER, and I used to work in the ER a ton, the first thing we do is put oxygen on you. The second thing we do is take your blood pressure. The third thing we do is draw your labs. Yeah. And you could have just had labs drawn yesterday. We know what your blood is. We know where your blood sugar is. but we're going to draw your labs. I promise you,
Yep.
those 3 things
Yep.
are going to happen to every
Yep.
patient that walks into the ER.
Yep.
We're going to draw your blood, and then we're going to go spend a lot of money doing blood tests on them. Even though the blood tests are quick and easy, we're going to spend a lot of money on it.
Oh, I was going to say, emergency medicine is really interesting because I think there's definitely a role for it. But to me, in some ways, so much of what goes on in emergency medicine is not emergency, right? So much of it is just inconsistent, chronic care where the chronic heart failure has failed because it hasn't been managed. The diabetes has failed because it hasn't been managed, and unfortunately, they ended up in an emergency room, right? And the emergency room's job is not to manage these. It's simply to stabilize and move it on. So it's, I don't know, that to me is, it's, I know that ER doctors are, it's a challenge for them because that's not the best use of their skills, their services, but it's thinking across the entire spectrum of care and trying to coordinate these things. I think there's lots of opportunities, but we have a ways to go.
We do. I got to tell you a story about, so I was at the ER in Orlando, Florida, and we had a patient come in just screaming and yelling, just screaming. We thought she was, drugs or addiction or, some kind of behavioral health thing. Couldn't figure it out. And you get close to her ear and she just starts screaming really loud. And so I go in and get Dr. Conley, who was an old ER doc, corpsman in the Navy. He was, had been in multiple combats, was in Vietnam and all that. And he grabs a otoscope, and we had this young lady papoosed into a board. And I mean, she's freaking out. Like, she's scaring everybody in the ER. And like, we don't know what's going on. And he puts a light, an otoscope in her ear, and sees a cockroach in her ear. And every time we get close to that cockroach, and I'm like, I don't know how to get a cockroach out of your ear. This is a real emergency. Like, I don't know what to do. And Conley goes, oh, I've seen this before. And so he grabs an 18 gauge needle and a syringe and a tongue depressor and some tape. And so he measures this ear that's not hurt with this was genius, I thought, with the tongue, or with the cap of the needle. And then he tapes the needle the tongue depressor right where the depth of her ear canal was. Yeah. And he fills a syringe full of alcohol and walks over and just punches it and squirts alcohol in that cockroach, kills it immediately, pulls it out, cleans her ear out, sends her home. And I'm like, I would have never done that. One. And two, like, you're a genius for thinking of that. And this girl, jumps up and hugs him and she loves him. And I'm like, I would have sitting there trying to dig that cockroach out forever. So it was a wild story. It's the one that I'll never forget. Like, there's only a few stories like that in the ER that I haven't forgotten, but that one I'll never forget. All right, let's talk a little bit about healthcare, retail, pharmacy. What experience at Walgreens teach you about traditional health systems often miss? So you guys, 25 countries, it's big.
I will be out of medicine, before this ever happens. But one of the great opportunities, and I saw it work from time to time, is that health systems and traditional healthcare is vitally important and is always central to what we do, right? But the majority of healthcare happens not in a health system. It happens at home. It happens as a consumer, right? Most of us, everyone that's probably listening on this call, in the last week, we've either had to make decisions about a cough, a cold, an allergy, a mosquito bite, or something. We've had to go to our local pharmacy or someplace to make some decisions about what am I going to use to do that, with our children, with our parents, with all those kinds of things, sunburn, all those kinds of things, right? To more complex things, managing, disease states and so forth. The majority of healthcare happens outside of a health system. It happens at home. And it's the people, even if they've seen the health system, like we've talked about before, they're making decisions about, am I going to take this medicine? When am I going to take this medicine? Am I going to get this test? When am I going to? They're making all these decisions outside of a health system. The role that pharmacies, the role that retail health, consumer health can play in that is huge, is absolutely huge. The opportunity for traditional healthcare to intersect and to utilize that, I think, is tremendous. For example, family medicines working with their local pharmacists are able to, make this tremendous experience so that the patient, by the time they get to the pharmacy, they already know it's cleared. The doctor already knows if that medicine's going to be covered. Being able to create that kind of communication between retail, consumer health, right, and traditional health system health, right, is the opportunity is tremendous. The other thing is it adds in the third leg, which is the patient themselves who's wondering, how do I do this? What do I do when I go? And again, many of those questions can be answered by the pharmacist, right? I forgot to take my medicine, or this medicine looks like they're saying all of those questions. The pharmacist could do that, some of them having to do with labs. Well, there's lab techs that could probably answer a lot of those questions without having to overwhelm, right, the clinician having to answer all of these questions and then try to divvy it all out. Like we talked about before, more and more healthcare is happening at home at all levels of acuity, right? Being able to utilize resources in the home, but being able to connect all that information into the traditional healthcare system so the person's physicians, the person's health system know about all of those things, right? Maybe making that all work together, to me, that there's just so many opportunities, and we have the tools to do that between digital health, between telemedicine, between AI. We have the ability to make those kinds of things happen. I'm both excited because I see those things beginning to happen in some places. I'm less excited because the payment mechanisms to be able to make all that happen. That was one of the things we used to deal with sometimes with the big payers, is saying, instead of paying, say, to manage diabetes only to the clinician, think about the patient and who is providing all of the care, right? And think about being able to pay based on the patient rather than based on the service. Because if you paid on the patient, then there's an incentive for all of those people to work together, because they're going to get paid if the patient has better outcomes. But when you're simply paying, we're going to pay this one for that, and this one for that, and this one for that, right? And then we're going to try to figure out what the value of each of those are. Well, how are you going to figure that out? You can't figure that out, right? If you based on is the patient's diabetes improving, right, and who is contributing to that, and we're going to each pay them a percentage. Well, now there's incentive to cooperate. So I know it sounds overly simplistic, but I'm hopeful that partly with technology and with better payment systems, that consumer element and retail element of healthcare, right? Because that's where so many people are getting their care, becomes part of the whole of taking care of patients.
Yeah, where do you see retail pharmacy fitting into that
So
in the future?
Yeah, so I think there's lots of opportunities. The challenge right now, I think, with retail pharmacy, like any kind of healthcare, is retail pharmacy at the end of the day is still a business, right? And they still have to make money, and so they're going to do the things, that help them to make money. You've seen Amazon do this very well. You've seen companies like Ro and Hims and Hers and so forth, right? Those companies are larger than Walgreens and CVS, right? Because they only said, we're going to just pick on a certain segment of care, and we're going to provide that really, really, really well, but we're going to do the segments of care that provide the most income, right? Definitely an approach. I understand why they do it, and they're very, very good at it, okay? Retail pharmacy, though, is kind of in this dilemma of they have to make money, but they also have to provide medication to everyone. And so how do you walk that fine line? Because providing medication for everyone doesn't have a big as margin as providing just very, very focused, types of care. And so partly they have some really, really big, financial challenges. But I'm hopeful that over time that some of the healthcare services that can be provided, that do need to be provided by, going to a place, can be provided more so in retail locations. Because as we saw during COVID, pharmacies are the only national healthcare platform that we have, right? It's the only way you can go to your local, in my neighborhood, right, provider, right? You can go to your local, because, between Walgreens and CVS, they cover something like, I don't know, over 95% of the population is within 5 miles of one of those two places. Well, that's a network. That's, and during COVID, when people had to get immunizations, they had to go to a location. That was the only network there was that was reliable. You could distribute it. So utilizing that footprint, right, could be extremely, extremely valuable allow us to provide services, some basic services, over across the country, and allow, I think, a business model for those retail pharmacies to be able to survive and thrive.
Yeah, it's you're right on, spot on.
A family member calls at 2 a.m., frightened, needing expert help fast. When you partner with IntelliTriage, a licensed nurse answers that call in under a minute, 24/7. We integrate with your EMR so our nurses have real-time access to your patient's care plans, and nothing gets missed. The result? Better patient care, less burnout, and stronger financial performance. IntelliTriage, nurse-first triage built for hospice and home health. Learn more at IntelliTriage.com.
All right, let's jump into your digital AI and health background. So you evaluated countless healthcare startups. What separates great companies from the rest?
Yeah, this is a great question. And when I was at Walgreens, we would evaluate over 1,000 different companies a year for all different kinds of things. So we saw literally thousands and thousands, right? Usually there's about two or three things. The first thing is what they've designed solving a problem, because you tend to see lots of things that get developed that are really cool technology, but it doesn't really solve the problem. Or if it does solve the problem, there's no way to pay for it. I remember one of the very earliest ones I saw was this pulmonologist from one of the major institutions in Baltimore that had designed an incredible spirometry. What it did was phenomenal, right? Right. But he couldn't get off the ground because spirometry is already provided in doctors' offices. So you're not going to sell it to patients, right? And because doctors already have this spirometry, they're not going to buy a new one. So he designed this incredible technology that it didn't really solve a problem. The second thing is, have they developed evidence about this, right? Companies tended to come to us in two things. They either had tons of evidence, right? Or they had tons of marketing, and they could really sell you they had incredible marketing, right? And the companies that really did the best could do both, right? Because I saw like some, especially out of university and so forth, they developed just incredible solutions, right? But they had no idea of how to market it. So they couldn't sell even any, right? And vice versa. I saw companies that had incredible marketing that could sell you like vapors, and people would go, yes, I want that vapor, but it didn't really do anything. And you would see after a year or two, the product just kind of faded away. So I think it's having a balance of evidence and kind of marketing, go-to-marketing strategy. When you do those two things well, you can really grow as long as what you're doing is solving a problem. I think the other thing that we tended to see is people, again, that didn't really have a clear idea of who would buy their product and how would it get paid for. You got to figure out, is this going to be paid for by insurance? Okay. Well, then you're going to have to make sure that this gets approved by insurance if that's how it's going to get, right? If you're going to go direct to the consumer, well, do you have an adequate marketing ability to get this out to the consumer so they can easily come to your website or whatever and purchase it, and you can get it to their home quickly and inexpensively, right? Because if you're selling, a $350 medical device, right, you're going to have to first get a prescription to try and get the device. You're going to have to pay $350. It's not going to come to your house for 2 weeks. Who's going to buy it? Nobody's going to buy that, right?
Right.
So it's figuring out who pays for it, and how do you have a way to get that going?
That's true. It's well said. What about AI? As you start looking at these AI companies, and I'm sure you're getting inundated with all of them. What grabs you? I mean, first you got to start with, is it secure? Is it PHI ready? Is it, HIPAA compliant? All that. Once you get past that question, where do you start going?
Yeah. I love this question because I've been looking into it a lot lately. The biggest thing that I see with AI, again, is that, what purpose is it trying to solve? What, right? Because it's really cool technology, and there's a lot of companies out there just sort of throwing it up, saying, put things in and see what spits out. Well, no, don't do that. Don't put things in and see what spits out. I think the biggest thing is AI if you kind of think about how AI works, what it's doing is it's taking data and just processing it like mega fast. Okay. So first of all, you got to think about where's the data coming from. Okay. There's processing, and no data is going to be 100% clean. You have to figure that in, but it's going to process. So things that are very data centric are kind of the low hanging fruit, things having to do with payments and scheduling and administrative functions, because they're kind of just data driven functions. So trying to, speed up, all of those kinds of things, I think, are low hanging fruit that can happen. And in healthcare, there's a lot of that. There's a lot of just kind of simple information crunching that could help out. And then, of course, the second area is like diagnostics. Well, again, you can train the AI to look at really, very minute diagnostic criteria, whether it's in labs, whether it's in radiology, whether it's in, tumor protein development. You can train it to look at really minute factors that can come up with some pretty interesting answers. The place where it becomes, I think, a little more interesting is when you begin to have to take in human input and then put it together with the data and making those two things intersect, right? So in those kinds of instances, I think of AI as being more augmenting, is taking, the clinicians in and the patient's input of having it be able to bring lots of data to the question, right? Because, one of the things we've talked about is even within a medical chart, if I have a chronic patient that I've been seeing for 25 years, trying to pull in all of that information quickly at the time. I mean, I'm seeing this patient for 15 minutes. I got to review all of the recent labs, the recent hospitalization, the recent radiology, any medication changes, right? I got to review all of that and see the patient within 15 minutes. Well, how are you going to pull all of that in and have a really concise idea? Well, one of the things that AI can do reasonably well is pull all the information in and summarize it, right? So you have a really quick overview of what that information is, right? The second piece of it then is all the quality elements, especially in home health and hospice. I mean, with all ACEs and CMS and, all of the different quality metrics that have to be assessed, right? And they have to be assessed very accurately. You got to be able to pull those in and look at those things quickly, right? But the clinician has to be the one making the decisions about all that information that's been pulled in, because they're the one looking at the patient and assessing the current state. So if you can take what's sitting in front of you, you can take the historic data and pull it together quickly, all of the guidelines, and pull all that together quickly. The clinician now can make a really informed decisions about what they're going. Because the other thing too, that's important about clinical decision making is clinical decision making isn't right that there's a right and there's a wrong. Clinical decision making is moving from point A to point B. Is pulling all this in and saying, based on that, my training and expertise says that we should move in this direction. So we are going to move in this direction for 2 weeks, 3 weeks, 1 month, whatever it is, and we're going to reassess at that point of time to see, is this improving or not? And then in 2 weeks, we're going to decide, based on that information, are we going in the right direction or not? And we're going to continue to go, right? Clinical decision making is just like flying an airplane. You don't fly from New York to Los Angeles in a straight line. You fly in 1,000 little small increments that are constantly adjusting around the way, and you arrive in Los Angeles. Clinical decision making is the same. You're going to keep this patient healthy by going this direction, this direction, this direction, constantly evaluating as you go along, having all of that AI to pull all of that information in for you quickly, right? So you have an idea of where you've been and as well as exactly where you are, allows clinical decision making to be more accurate, more timely, more cost efficient. So I'm excited about what AI can do, but only when you have, for those kinds of things, clinical decision making, where the clinician is still making the decision and they're utilizing the very best resources to pull it in. And last thing I say about that is that, in effect, that's what clinicians have always done. Clinicians, in a way, have always had to go back through and look at all of the labs, go back through and look at the last 2 visit notes, go back through and look at the latest guidelines, go back through and look at the x-ray that was done, right? And then pull all that together and say, okay, based on this, this is what I see, right? What AI is doing is being able just to do that quickly and more thoroughly, right, than the clinician having to do that for all of these different things individually.
Yeah, we kind of branded it around here: clinical intelligence versus artificial
I
intelligence.
love that.
I hate
I
the term
love that.
artificial,
I do
but
too.
it's really just an angel on your shoulder helping you, right? It's the old saying where a doctor had to spend 20 minutes prepping for a patient for 15 minutes just because you had to read the chart and all that. Well, if I can give you that quicker and I can summarize your whole day. Here's the 14
Right.
patients you're going to
Yep.
see today, and here's what's
Yep.
going on with each
Yep.
one of them, and
Yep.
here's the latest labs, and it can coordinate all that. We had a scenario the other day where I got a call from a client of mine. It's a bizarre one, but it was a great use case for AI. So, what is the patient's weight and their height equals the size of bed they wanted to buy them for hospice? And so what happened was all the nurses were ordering these extra large beds because it was the easiest. You just click that button, extra large. Well, you have a 98-pound, 85-year-old female in an extra large bed. She doesn't need that. By the way, the cost of that bed is $45 more than a small bed.
Right.
And these are
Right.
these specialty hospice beds.
Yep.
And so what we found is we could easily build an algorithm that said, hey, based on what we know about the patient, we know their weight, we know their height, this is the bed you need. Drop that into the order versus let you pick the extra large bed. And we save $45 per patient. We were just throwing money in the trash. And by the way, the vendor's like, hey, I have 8,000 extra large beds and 3 small beds because you never order them. And we're like, what are we doing wrong? I mean, it's just a perfect use case for AI. Versus, having to go train everybody how to do this. Just let AI build that for you. It's a great one. All right, we're getting close to our time, but I want to ask you a few more questions if you have time. If you were rebuilding healthcare from scratch today, what would you do differently? If we made you head of CMS or HHS, what would you do
Yeah.
differently?
Yeah. Well, I'm going to answer this in the hypothetical world rather than the real world. But I think the first thing we've kind of talked about all of this already. But the first thing is I would have a single EMR platform, right? So that there's one record for a patient that everyone has access to, right? It doesn't eliminate competition. Everyone can still be utilizing that, building off of it, creating bells and whistles and so forth. But there's one record. Okay? That would be the first thing.
Love it.
The second thing is I would take a look at payment systems again. Like I said, we were in 25 countries. We worked with a whole lot of different payment systems, right? There's not necessarily one that's the best. There's definitely some that are better, but it probably has more to do with the locality than necessarily the payment system. I think a multi-payer system can work really well, but a multi-payer system works well if what's being rewarded is the patient outcome, right, and not the reduction in cost, right? So if you have good patient outcomes because you have good interoperability, because you have really efficient use of resources, right? Everyone's going to win. The payer's going to win. The patient's going to win. The system is going to win. And it's going to cost everything way, 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 way less. But you still have the competition to want to be able to create that kind of energy. Right now, our payment systems are not designed to do that. So I would, like I said, I'd have a single medical record, and then I have a payment system that rewards outcomes much more strongly than what we do.
As big as United Healthcare and Humana and Aetna and Blue Cross Blue Shield and all these guys are, you would think they'd figure this out. They're the ones that could guide it and drive it. I mean, even when I was in the Navy and we had 4 or 5 different health records that we were using, but we still had a single record for everybody. And the government was trying to solve that. I mean, that was 1995.
Well, and the thing that I really wish that they would do more of is that they would try to incentivize the interoperability that within them. Because right now, what I see a lot of them doing is they're wanting to be the one to assume care. They're basically going, doctors won't listen to us, the pharmacists won't listen to us, the radiologists won't, none of these people will listen to us. So we'll do it because we have the information. So we'll just do it ourselves. Well, no, that doesn't work because all you're doing is adding another voice, right? That wants to have input into what you're doing. You don't need another voice. What you need is the voices that are already taking care of them to be able to interact easily and economically. So, I agree. I think they have opportunities. I understand, from a business standpoint, why they do what they do. But from a healthcare standpoint, I think they could have a better business model and also have much better outcomes.
True. All right, got the legacy question. When you think about your legacy, what impact do you what impact do you hope that you've had on patients, physicians, and the future of healthcare?
Oh, yeah. So I would say that the very first thing is integrity. When I was at Walgreens, I was the chief clinical integrity officer. My job was for this multi-company is to make sure to the very best degree that we could that we had the highest degree of integrity we can. Those are difficult decisions. It's a big company, and that road is challenging. But one of the things that I believe very, very much in is evidence-based healthcare, right? Is that you use the very best evidence you have at the time you have it, and you make decisions based on the very best evidence. The first thing is I would want to leave a legacy of integrity, that you always try to use the very highest level of evidence you can. The second thing is to be able to help to provide care, to elevate the ability for people to receive care, information at home, to be able to make the decisions of when do I need to go to a hospital, right? Where do I go to get information? Where do I go to get treatment, care, right? All those kinds of things. Because, like I said, 99% of our lives are spent at home, right? So understanding how to take care of at home, I tried to do that partly by being a family medicine physician, of being able to work with people, right, on an ambulatory basis in their homes, partly of working for a big consumer retail company, now working with a number of companies that do that in various situations. So being able to elevate the quality of care at home would be kind of the second thing. I would say those are probably the two biggest things: is integrity, evidence-based care, and elevate the home care experience.
It's really awesome. Well, Dr. Robson, thank you so much for being part of this. If people want to reach out to you, I can get you on LinkedIn. They can go look at the companies you're invested with. I think you have them all
Yes,
listed on there
yes,
and
yes,
working
yes,
with. So Cole will
yes.
post that in the show notes for us. And thank you for your service, for what you've done for medicine and Walgreens, and thank you for being on the show. It's been a real
Great.
pleasure to have you.
Yeah, thank you. It's a wonderful dialogue with you. I feel like I want to have 2 or 3 more. So
We should.
maybe I'll so thank you so much for this opportunity.